All right, hey there, everyone.
Right, listen.
I'm actually blown away. There's a person here today. So usually it's just me making a recording. So
Only listen around 30 minutes. I'm waiting for my flight.
oh, gotcha. So you're just logging in for a little bit.
Mm. Yeah,
All right.
and I will review.
Um,
I will review. Yeah, especially the case study parts.
gotcha. Well, before I get started, do you have any questions on anything? Like, I don't know if you've been watching the videos so far. Any questions or anything like that?
Um, n- Not yet.
Okay. All right. Well, jump in if any questions or anything come up. Just feel free to jump in. But if nothing, I'll just kind of continue with going through the recording and everything and creating these recordings. Okay. So where we had left off last time was we had started on the review of muscles and bones. So basically, this handout here, it's going to cover the anatomy and physiology one. So it'll cover some basics about the musculoskeletal system, muscles, bones, muscle actions, that kind of stuff. And also mixed in with this is going to be the ONE2 material. So mixed in with this will be things like the special tests and things like thoracic outlet syndrome and stuff like that. And what are the tests that we use for that? So we had already started that last week. So we had left off with this here. We had gone over thoracic outlet syndrome and the various tests. So we're going to pick up here with upper extremity. So we'll get through this handout. And then the last major topic that's left is going to be going over the case study section. So going over what to prepare for as far as that goes. And then obviously if there are people here, if anybody had questions, there's time sort of baked in for any questions, any fine tuning. But if it's, just me making a recording, that's probably where we'll end. And then if you have questions, you could always email me if anything comes up. So, all right. Well, if nothing for now, let's jump into this.
Sorry. Actually, I have a question. So
Sure.
for the bioscience parts, if we don't have enough time, should we focus on the Comp2's materials? We don't need to at the same time to review your Comp1's bioscience materials, right?
All the comps one material is already baked into this, so it's already in here. So like comps one, like for example, like going over muscle bones, we went over things like the scapular landmarks, the acromion process, the carpal bones. Like that's the stuff that's in the comps one notes, and it's already baked into these handouts. So it's the same thing for all the handouts. The
So we
comps
just need
one
to focus
bios
on the Comp2's materials
for the
bioscience
bio
part.
for the bio stuff, yeah. There are separate handouts for like the acupuncture channels and stuff that I gave you those handouts in the comps two folder that are repeats from comps one. So those, make sure anything that I put in the second year handouts that you go over those. But yeah, this
Okay.
it overlaps. It already
So
includes the
it's
anatomy.
so especially we should focus on the red wording, right?
The what?
That the red words.
Well, those are the notes that I typed in over time and I've saved, but I wouldn't say just know those. Like, because for example, know the carpal bones, like in the regular print is the names of the carpal bones. So you've got to know those. It's just the stuff in red is the stuff that when I was originally teaching this, a lot of this was open, like it was more of an outline. And then as we went through the review class, I typed things in as we were going. And then I've just saved it over time. So this red stuff is like additional things that I've typed in. But I mean, all of it's important. Like, you should know that supraspinatus tendonitis is tested for with the empty can test, even though it's in dark print. The red's just additional notes is all.
Okay, thank you.
So yeah, I wouldn't take that into account. Just know what's here. All right. All right. So let's pick up where we left off last time on this handout. Let's go into the details of the upper extremities. So again, we'll focus on it like we'll do a recap of the anatomy physiology, the relevant muscles, bones, bony landmarks, muscle actions, etc. And then when we're going over certain regions, we'll talk about if there's an orthopedic condition that you should know and what's the special test for that condition and thing, what kind of signs and symptoms come with that condition, etc. Okay. The upper extremity. So first off, we start with the scapula. We have the scapula that is the most proximal part that helps form that upper extremity. And there are some landmarks on the scapula that could come up on the exam. Now, most of the questions with when it comes to like the bones and bony landmarks are just things like which of the following landmarks are on a certain bone, or this landmark is on which of the following bones. Like, in other words, it could be phrased in either direction. You're not labeling pictures or anything. You're not pointing them out on models. You just have to recognize that, for example, the acromion process, it's not its own bone. It's not its own thing. It's a landmark on the scapula. And you have to know that it's on the scapula, not the clavicle, not the humerus. So you can get asked about things like that, that the acromion process, this thing here, this area here, is a landmark on the scapula. There's also a landmark called the coracoid process. That's a little bump that you could feel. You kind of feel it more on the anterior side here, but it is coming from the scapula. It just projects quite a bit anteriorly. So you feel it over here, the coracoid process. Then, of course, you have the spine of the scapula, and that's where you find a lot of small intestine channel points along the spine of the scapula. And then you've got that depression called the glenoid fossa. And the glenoid fossa is the depression that essentially receives the head of the humerus. The head of the humerus fits into that glenoid fossa to form that ball and socket joint that we know as the shoulder. Or you could be a little more technical and say we know it as the glenohumeral joint because it's a junction of the glenoid fossa and the humerus. So the more technical term is glenohumeral joint. A lot of times we refer to it as the shoulder joint. And remember, it's a ball and socket joint. It is the most freely movable of all your joints. You can move it in all planes, very flexible generally. So you want to recognize some of these landmarks. Now, there is a condition where somebody can have a wing scapula, where the scapula kind of wings out rather than being held firmly against the rib cage. And there is a question that comes up on comps. I mean, I don't know if you'll get this question, but it is in the test bank. And the question asks, what causes a wing scapula? Now, there's two potential answers. It could be that the muscle itself that holds the scapula to the thoracic wall, which is the serratus anterior muscle, it could be that there's some kind of problem with the muscle itself. But the question in the comps database, that's not one of the options. It doesn't ask about the muscles. It asks about nerves. Which nerve must be defective, not working? And you want to know that it's the long thoracic nerve. If there's some kind of injury or deficit to the long thoracic nerve, that's the nerve that controls the serratus anterior. So that's the nerve that would be the problem nerve if the scapula is winging out. Right. Now, just as an FYI, like I'm mentioning this because this is one, even though I'm telling you like this is a specific question and I'm not generally telling you like exact questions in the review class. The reason I'm mentioning this one is this is just one of those, somewhat nitpicky things. I know the long thoracic nerve is probably not a nerve that's like overemphasized in a lot of your classes. So it's one of those things that often, people don't know the answer to unless they're told like, hey, you have to know this detail. But I want to point out that this is another example though of ones where a lot of times there is one answer that looks kind of obviously correct. And this kind of falls into that because on this question, let's say I hadn't told you anything. When you look at the options, the wrong options are nerves that aren't really anywhere near the scapula. Like the wrong options are things like sciatic nerve injury. Well, sciatic nerve's in the back of the leg. That doesn't affect the scapula. Another one I think is like the phrenic nerve, which we know that controls the diaphragm. That's not controlling muscles that regulate the scapula. So like when you go look at the options, there really is only one nerve that would be in that general area. Even if you're like, I've never heard of the long thoracic nerve. Well, I mean, the scapula's over the rib, basically overlapping the rib cage. It's overlapping the thorax. So kind of makes sense that there might be a nerve in that area called the long thoracic nerve. So again, just one of those examples of something where even if you didn't study the specific information, there is one answer that should kind of like jump out at you as probably being the right one. And in this case, it is. So again, remember with the comps, obviously always go with what you know for a fact. But if you're ever taking a somewhat of a guess, if there is an answer that looks like it's probably right, go with that because many answers on the comps, the obvious answer is the correct answer. All right. So then after the scapula, we go into the humerus. We then go into the radius and the ulna. And, there's certain things that hopefully at this point you know about those. The humerus, you have the greater and lesser tubercle, you have the medial and lateral epicondyle. I'm not really emphasizing those here because those are in a lot of your other notes and they come up when like your channel pathways and stuff. Then you get to the radius and the ulna, radius on the thumb side, ulna on the pinky side. And of course, you want to know your basic landmarks on those. You want to know, like, for example, the olecranon process is part of the ulna. Then when you get distal out here, you have styloid processes on each of the radius and ulna, but not really too much that comes up with those bones. Then you get to the carpal bones. And the carpal bones, you want to make sure that you recognize those names. So remember, there's basically 8 carpal bones, 8 tiny little bones that we call carpal bones. Carpal, because they're found in the area of the wrist, they help compose the wrist joint. They're 8 little bones organized in 2 rows, and there's basically a proximal row, meaning a row closer to the forearm, and then a distal row, meaning closer to the palm. And this is the order of the bones from lateral to medial. So, in other words, from thumb side to pinky side, and then listing the proximal row and the distal row: scaphoid, lunate, triquetrium, pisiform, trapezium, trapezoid, capitate, hamate. Now, again, you're not labeling a picture. So all you really need to do is make sure that you recognize those bones as carpal bones. Like a lot of times the questions that come up are just as simple as where in the body would you find the capitate bone? And you just have to recognize, oh, that's one of the carpal bones. So the answer is I'd find it in the hand or the wrist as opposed to the foot or the head. So make sure that you recognize those names as carpal bones. Don't worry too much about the exact order. I've never really seen any questions come up where you have to put them in order or anything. But remember there are all sorts of mnemonics for remembering the order. Like you might remember sayings like some lovers try positions that they can't handle, where the first letter of each of the words in the saying corresponds to the first letter of each of the carpal bones in this order: lateral to medial, proximal row to distal row. So you can certainly remember the order, but most of the questions just relate to recognizing them as carpal bones. Then, of course, we go into the metacarpals that make up the palm and the phalanges that make up the fingers. I've not really seen too many questions on those, but just remember that when we're talking about whether it be the metacarpals or the phalanges, we number them 1 through 5, 1 being the thumb side, 5 being the pinky. And then remember that the more proximal part of those bones is called the base of the metacarpal or the base of the phalange. And the more distal part is called the head of the metacarpal or head of the phalange. But again, not really a lot of questions that come up with that stuff. But that's just basic anatomy. So you want to know some of that. And then make sure you know the terms pollicis and hallucis, referring to thumb and big toe. So pollicis referring to thumb, hallucis to big toe. And this is another example of something where there could be a question that comes up that seems like it's harder than it is. Like, for example, I've seen questions come up in the test bank where it'll ask you, what's the function of the extensor hallucis longus muscle? And you might get some people like, whoa, like I thought they were just going to ask about big muscles. I didn't really study the extensor hallucis longus. But if you know hallucis means toe or big toe, and you look at your options, one of the options is going to be extend the big toe. And it's right in the name, extensor hallucis longus. It's telling you it's a muscle that extends the big toe. It's right in the name. So again, there are some questions like that where it might, at a first glimpse, appear like it's a hard, nitpicky question. But when you look at the options, it's like actually a fairly obvious question. And that's why I just keep emphasizing, don't go down that road of thinking something's too easy. If there's an obvious answer, go with it. I can't emphasize that enough. There's just too many times where I see people that, you know, the ones that don't pass and I look at their exam, some of the mistakes they've made were just things like that, where they would say the extensor hallucis longus flexes the head or something like that. And it's like, oh, okay. Then, as far as some muscles that move the upper extremity, we'll mention a few as we go through some of these O&E tests as well, but a few that don't really have a specific O&E test that we want to highlight is the pectoralis major. Remember, the pectoralis major is going to essentially run from your sternum and your ribs and run in this direction and connect to your humerus here. So when this muscle contracts, it pulls your humerus towards midline. So it does what we call adduction of the humerus. It also, because if you're here like an anatomical position, it also can kind of pull the humerus into what we call internal rotation, internal or medial rotation. So those are going to be the primary actions of the pectoralis major. If you get a question about the pectoralis major, those are going to be the primary actions. Now, if you were to go to your trail guide to the body, you're going to see a whole bunch of functions written for pectoralis major because you may recall that the muscle fibers run in different directions, different orientations. Basically, there's some muscle fibers that kind of originate up here, so they're kind of running somewhat downward, some that are going directly across, and some that are running somewhat upward. So depending on exactly which muscle fibers get activated, it can assist with a variety of different actions. But the two primary ones that will likely come up on comps would be these two. Everything else, it's just like, yeah, it could help a little bit with moving the shoulder joint or moving the humerus in those other directions. These are the primary ones that I focus on. Then remember, we have the latissimus dorsi. It originates kind of on the low back and then it narrows down into a single, like basically one band of muscle that comes up and attaches to the humerus here. And when this contracts, it can pull the humerus down into an adducted position. So it pulls it down like this, closer to the body core. Also, it can medially rotate because it's kind of running under the armpit, attaching and pulling you into this kind of position. So it also does internal or medial rotation. And because it is more on the back side, it can also pull the shoulder joint into an extension position, pull you back like this. So that's why if you think about how we work these muscles, when somebody wants to work the latissimus dorsi, they might go to the gym and do those lat pull downs where they grab a bar up here and then pull it down like this because they're doing adduction and maybe even pulling a little into extension. You might do rows, same kind of thing, a rowing motion, pulling the shoulder joint back into an extended position. Pull ups, where basically you're moving your body against gravity, but you're doing the same kind of motion. So you're using that muscle primarily to do that. Where when you want to work your pec major, typically we're doing things like flies. We're doing something where like crisscrossing our arms in front of us, maybe using cables, because we're pulling our joints here into a horizontally abducted or adducted position. All right. And the tricep brachii, remember, that's going to run from the scapula down to the ulna here, and it's going to pull the shoulder into an extended position, and it's going to extend the elbow. So it's going to do this type of thing. That's why sometimes he'll get a dumbbell and they'll do something like this when they want to work their triceps. And you should know the radial nerve. The radial nerve is going to be the nerve that innervates the triceps and basically the entire posterior aspect of the upper extremity. So if you get any kind of question about what nerve innervates the tricep or the extensor muscles in the forearm or conducts sensation from those regions, you want to know that the radial nerve is what's going to innervate the posterior aspect of the upper extremity, radial nerve. And just to remind people real quick about how the phrasing that we use when we're talking about muscle actions. Remember that there's words that indicate essentially what direction the bone is moving in. Flexion versus extension. We mentioned these last week. Abduction, adduction. Those terms denote like what direction the bone is moving in. Is it moving anteriorly, posteriorly, medially, laterally? And then you can reference the joint where the motion is occurring. So you can say like adduction of the shoulder, or you could be use the more technical term, adduction of the glenohumeral joint. You can reference the joint where the motion's occurring and then use the appropriate word to denote like what direction it's moving in, adduction versus abduction, or you can reference the bone. So in other words, you can say adduction of the shoulder joint, or you can say adduction of the humerus. It would be the same thing. So just know, like on a comp exam, they could phrase it either way. And so that's why I kind of purposefully did that here, where I said like adduction slash internal rotation of the humerus or of the shoulder joint. Like that's why I kind of go back and forth sometimes in whether I reference the joint or the bone, just to emphasize that you could do it either way. Same thing. All right, so that's some of the key anatomy reminder, anatomy, physiology one stuff that you should know about these. Now going to the O&E2, the conditions, the special tests, what you should know as far as the upper extremity goes. So one diagnosis that you learned is supraspinatus tendonitis. You might recall you have your supraspinatus muscle that's kind of up here around where small intestine 12 is. And that's a muscle that when it contracts, it pulls your shoulder joint or your glenohumeral joint into abduction. It pulls you into this position. And it helps the deltoid. Like the deltoid also helps do this, but the supraspinatus is a smaller muscle deep to the deltoid that typically is what initiates it. And then the deltoid adds that like extra force. So if somebody has tendonitis of this tendon, which is not uncommon because this tendon is running underneath the acromion process and attaching to the humeral head. So sometimes it's getting like it's getting increased friction. The fact that it's kind of moving underneath that acromion process, sometimes it's encountering a lot of friction. And then the tendon becomes irritated, inflamed, what we call tendonitis. And then the person gets pain when they do those kinds of motions. When they put tension on that tendon, they're going to get pain. And certainly, if that tendon gets pressed into the acromion process, it's going to be painful. So that's why they tend to get pain with abduction and also pain if you internally rotate the shoulder, because that tends to push the tendon up into the acromion process when you internally rotate. So, as we mentioned last time, most of these special tests are essentially reproducing the mechanism of injury and just in a controlled environment assessing what motions are creating the pain and whatnot. So what you essentially have the patient do is go into an abducted position. You have them internally rotate their shoulder and pronate their forearm. So that's why they sometimes call this empty can test, because it kind of looks like they're emptying a can out like this. They hold this position, and then you as the examiner apply downward pressure and they resist you. So in other words, they're engaging that muscle. And if they have supraspinatus tendonitis, you would imagine that, like, yeah, that would hurt. That would be uncomfortable. That would trigger pain for them. And that would be a positive result for this test, supraspinatus test or empty can test, indicating supraspinatus tendonitis. Now, one thing I just want to remind you of, remember that the supraspinatus muscle is one of your rotator cuff muscles. So one way they could phrase this is rotator cuff dysfunction or inflammation of the rotator cuff. They could phrase it that way. Rather than specifying the supraspinatus, they refer to it as like rotator cuff injury or inflammation. So just make sure you remember the supraspinatus is one of the rotator cuff muscles. So those are not like different things. There's overlap. Now, then we have something called impingement syndrome. Now, impingement syndrome is the same basic concept of supraspinatus tendonitis, but impingement syndrome, what we're saying is that either the supraspinatus tendon and or the bicep long head tendon are literally being impinged, in other words, between the acromion process and the head of the humerus. So basically, there's not enough room. Like literally, they're being pinched. So it's a little bit beyond just inflammation. We're not saying that it's just the tendons are irritated. We're saying literally they're being compressed. That's what they call impingement syndrome. So here, this doesn't require any kind of like muscle tension or any force generated upon the muscle in order to exacerbate the injury. So this is the one where they call this Hawkins-Kennedy impingement test. You, the examiner, pick up their upper extremity like this, and then just you as the examiner put them into an internally rotated position because that jams the head of the humerus into the acromion process. So you do that. In other words, they're not generating any force at all. They're not even using the muscle. They don't have to here. You just do this, and if they're like, "Oh, ow," that indicates that yeah, those tendons, there's not enough room in that space, and those tendons are getting compressed. And that's why they didn't even have to use their muscles. They didn't even have to generate any force. All you needed to do was just slightly move this joint in the in the wrong direction, so to speak. And that was it. Like, ow, that hurts. That indicates impingement syndrome, which is impingement of the supraspinatus tendon and or the bicep long head tendon. And that test is called the Hawkins-Kennedy impingement test. Then you might recall that a lot of synovial joints, particularly your ball and socket joints, where there's a lot of movement, the joints are more freely movable. There's like a lip of cartilage around the outside of the joint just to provide like a little more depth. And we call that lip of cartilage the labrum. And sometimes when there's an injury to one of those joints, pieces of the labrum break off. The labrum gets injured and pieces of that cartilage break off and get into the joint space. And then the person essentially has debris floating around in the joint space. So when they use that joint, the debris is, bumping into everything, creating more friction, and it leads to pain and irritation. And because there's a lot of debris, they might hear it, they might feel it. You as the examiner might notice that there's sort of like a crunchy or grinding sound or sensation, like it just feels like rough when you move it, and you might hear or feel like some degree of like grinding or crunchiness. That indicates a labrum tear, and the test is called clunk test. This is just where you, the examiner, will move the shoulder joint in various degrees of motion. And if you notice what we're talking about here, this crunchy, grindy sensation or sound, that would be a positive clunk test indicating a labrum tear. Now, again, you don't have to actually perform these exams on a practical or anything. So, for purposes of comps, you just need to basically be able to recognize positive clunk test that equals labrum tear. You suspect somebody has a labrum tear, you want to do clunk test. Again, they could ask it in either direction. What does a labrum tear look like? How does it appear? How does it present? Again, crunchy, grindy type of sensation when you move the joint. That's all. You just want to have those kinds of things in your head. They're very straightforward multiple choice questions. It's just that there's a lot of tests and keeping them straight is the hard part. It's not that the individual questions are nitpicky. Then another possibility is somebody can tear the ligaments that hold the humerus and the scapula together. And if the ligaments are damaged, then the bones are not going to be held together properly, and there's going to be some kind of laxity. There's going to be some kind of like dislocation that the person is susceptible to. And most commonly, the shoulder joint either dislocates anteriorly or dislocates posteriorly. And the tests are very simple, simply named. Anterior apprehension test tests for basically an anterior shoulder dislocation, and a posterior apprehension test tests for a posterior dislocation. And you may remember this is the one where the anterior apprehension test, this is the one where the patient is lying on the table supine. You have their shoulder joint like this, and you start kind of cranking their arm back like that. You start externally rotating the shoulder joint, and you're feeling this location. And you're going to either feel like if it's a positive test for an anterior shoulder dislocation, you're going to feel the humeral head popping out. So either you might just feel that and go, yeah, okay, yeah, they've got a dislocation. Or the reason they call it the apprehension test is the patient feels it about to pop out. And before you even notice it, they kind of get a look of like, oh, because they feel it about to pop out. So that's why they call it the anterior apprehension test. And that's testing again for anterior shoulder dislocation. Posterior is the same concept, except in a posterior apprehension test, you're essentially pushing the humerus in a posterior direction. You have them hanging over the edge of the table, essentially. They're laying on the table supine. You have them sort of hanging over the edge, and then you like push back as you move the joint a little bit. And again, they'll get a look of apprehension on their face as they feel it start to pop out. Then we have bicipital tendonitis, where basically the bicep tendon becomes inflamed for whatever reason. Now, remember, the bicep has three major actions. It flexes the shoulder, or you could say flexes the humerus. So, in other words, it moves the humerus in an anterior direction. It also flexes the elbow. So, it moves the forearm bones in an anterior direction. So, make a muscle, that kind of thing. And it's also a supinator. It supinates the forearm. So, the bicep muscle, you want to know that it does all of those actions. And sometimes, people get inflammation of the bicep tendons. They're going to get pain if they do those actions. So they'll come in maybe complaining that they have pain that's worse with shoulder, elbow flexion. And then you in the office want to reproduce that, test it for yourself in a controlled way. That's what we call speeds test. And speeds test, you're essentially having them the shoulder and the elbow against your resistance. So you're having them do this as you're pressing down, and you're seeing if that elicits any kind of pain. That would be a positive speeds test, and a positive speeds test would indicate bicipital tendonitis. Then we have medial and lateral epicondylitis, also known as golfer's elbow and tennis elbow. Now, here, there's a couple of potential origin insertion type of questions that can come up when it comes to this stuff, because you may recall that the reason these conditions exist is because all of the muscles that flex the wrist and flex the fingers, help you form a fist and flex the wrist like that, all the muscles in the forearm that attach to the base of the hand, that attach to the fingers, that allow for flexion of the fingers, flexion of the wrist, you might recall they all originate at this medial epicondyle. They all originate at the medial epicondyle of the humerus. And then they run down the forearm and they attach to various areas along the base of the palm here and distally to the phalanges. So when they contract, they pull everything into this like flexed position. Well, because there's a lot of muscles all within the forearm that are all attaching, all originating on this one landmark, what can happen is if these muscles get really tight from overuse, then they can pull on this origin site. They basically pull on the fascia of this origin site, leading to inflammation. The tissue basically becomes injured, becomes a little torn, and it's really painful. And it's going to be worse when you use those muscles. So that's what we call medial epicondylitis. And it's also referred to as golfer's elbow because a lot of golfers get this from I don't play golf, so I don't really know all the details, but I guess when they swing the golf club, they have to do this kind of motion a lot and causes these muscles to hypertrophy and everything. So there's kind of two ways we can test for this. We can have them flex their wrist, apply resistance in the other way, Now we're engaging these muscles, and if that elicits pain, that would indicate medial epicondylitis or golfer's elbow. Or the other side of that coin is you can overstretch those muscles. So you, as the examiner, can stretch those muscles, apply tension, same kind of thing. That's going to pull on these muscles, pulling on this origin site. And if that elicits pain in this area at the origin site, then that also would indicate medial epicondylitis or golfer's elbow. And we basically have the same principle, the same idea, but just for the other side now. So you might recall the extensor muscles, all the muscles on the posterior aspect of the forearm that extend the wrist and extend the fingers. Those muscles all originate on the lateral epicondyle. So if you're doing a lot of motions that require extension of the wrist, like hitting a backhand in tennis, that's why it's called tennis elbow. Hitting a backhand in tennis requires that. These muscles then hypertrophy, leading to pulling at this origin site. And then the person gets a lot of pain in this area, particularly when they extend the wrist and the fingers. And now it's really the same principle as far as the test goes. The lateral epicondylitis test, also known, you could see here as Cosen's test. You could do the same kind of thing as what we were saying on the other side. You can have them extend their wrist and apply resistance in the other direction and elicit pain, or you can overstretch those muscles, put tension on the muscles. And if that elicits pain, then that would be a positive lateral epicondylitis or tennis elbow. Positive lateral epicondylitis test or Cosen's test, indicating tennis elbow, I should say. Since we do have somebody here, any questions on anything so far? All right. Then we have what we call cubital tunnel syndrome. Cubital tunnel syndrome. So you may recall the ulnar nerve runs in between the olecranon process here and the medial epicondyle, the humerus here. And this is where small intestine 8 is located. And this is also what we call the funny bone because the ulnar nerve runs in this little groove. So if you hit this area, it sometimes hits the ulnar nerve, and that's when, your hand, forearm goes a little tingly and whatnot. Well, sometimes what happens is that the little tunnel, the little opening, the little groove for the ulnar nerve is sometimes narrow, or maybe there's a bone spur growing into that space, whatever it might be. There's something in that space that's compressing the ulnar nerve in this cubital tunnel area. And that leads to a sensation as if you just whacked your funny bone. So it typically leads to like a pain, tingling, or numbness down this medial aspect of the forearm, because that's the area that the ulnar nerve innervates, into the fourth and fifth fingers. So if somebody chronically has sort of a pain, tingling, and numbness in those areas, it could be because the ulnar nerve is being pinched in that cubital tunnel. So the test for that, they call it the elbow flexion test. Very simple test. You have the patient basically hold this position. I'm going to move over so you can see one side, but you'd have them do it on both sides for comparison. You have them hold this position. Basically, their shoulder joint is in a slightly abducted position. Their elbows flexed. Their wrists and fingers are extended. You have them hold this position. This position puts some tension on the ulnar nerve. So if they do have something injuring the ulnar nerve, when you put it into this sort of more tension-oriented position, that's going to likely exacerbate it. So they're going to start to say that, like, yeah, that's getting worse. I'm feeling that more. That's aggravating it. And that would indicate that it's what you're thinking, that it's a cubital tunnel syndrome, that the ulnar nerve is being pinched in the cubital tunnel. So the name of that test is the elbow flexion test. All right. Then, of course, we have a very common one, carpal tunnel syndrome. Remember that right here around pericardium 7, you have the median nerve running through, going from the forearm area into the palm of the hand. And the median nerve, you might remember, innervates the thenar eminence here, the thumb, the index finger, the middle finger, and actually even the lateral side of the ring finger here. So the median nerve kind of innervates this area of the palm and the first three fingers primarily. So what can happen sometimes is you also have all of those tendons that flex the fingers and flex the wrist running through this area as well. So what happens if somebody's doing a lot of work with their fingers, a lot of things where they're having to use their fingers a lot, typing, you know, a lot of writing, a lot of just anything where they're using their fingers for fine detail control on a regular basis, all the movement of all those tendons over time can sometimes irritate that median nerve. Sometimes the tendons themselves become a little irritated and swollen, and that puts pressure on the median nerve. Bottom line is that median nerve becomes compressed in what we call the carpal tunnel. And that's going to lead to pain, tingling, numbness in that thenar eminence area, in the first three fingers. It might radiate up the forearm a bit. They might get atrophy of the thenar eminence. Oftentimes, they give you a history of this is a person that, you know, does a lot of typing or something using their fingers. Those signs and symptoms indicate what we call carpal tunnel syndrome, compression of the median nerve in that carpal tunnel. And there's two tests for it, and they're very simple tests. There's Phelan's test, where you have the patient put the dorsum of their hands together like this and hold this position. You know, you have them hold it for 30 seconds or so. And essentially, what you're doing is you're further compressing that carpal tunnel by holding that position. And if they're like, oh, yeah, oh, that's making it worse, that would be a positive that'd be a positive Phelan's test indicating carpal tunnel. There's also reverse Phelan's, which is called prayer test. You'll have them hold this position. And basically, when you do this, you're stretching the median nerve, you're putting tension on it. So you have them hold this position and same kind of thing. If they're like, yeah, that's making it worse, that would indicate carpal tunnel syndrome. So again, just notice that, I've mentioned this before. The stuff that I'm including is already very narrowed down, right? You have plenty more notes from your O&E2 classes on this stuff. So don't further narrow it down. You want to know that it's the median nerve as opposed to some other nerve that's being compressed, that these are the key signs and symptoms that you could test for with Phelan's and reverse Phelan's. Like if you know this stuff that's here, it should be enough to answer these multiple choice questions on comps, but don't further narrow it down. Then we have osteoarthritis, sometimes referred to as DJD, degenerative joint disease of the thumb. Now, of course, we can get osteoarthritis of any joint, and we can do a similar test for any joint, but for whatever reason, the one that's on the list of exams that's fair game for comps is the grind test, which specifically refers to osteoarthritis of the thumb joint. But just know, in principle, you could do this same type of mechanism on any joint and test for arthritis of other joints. But the one that comes up for comps is basically a person has pain when they're moving their thumb, and that could be from overuse, like a lot of video games, texting, doing something like this over and over again. They might develop osteoarthritis in these joints in here that move the bones of the thumb. And grind test is essentially where you stabilize the proximal bone and then you grab the more distal bone in the joint that's affected and you kind of push them together and you twist a little bit. In other words, you grind them. Now, again, not aggressively. We're not trying to further injure the person, just enough to see if, like, you trigger their signs and symptoms. So you stabilize the proximal bone, grab the distal bone, push them together, do a little twist. In other words, you're grinding. And if they're like, yeah, ow, that would be a positive grind test and indicate osteoarthritis of that thumb joint. All right. And then lastly, as far as the upper extremity goes, lastly for the upper extremity, and this is one that it's very straightforward, but it's also like it is one that sometimes people miss a lot because of all the different names. Notice that the condition is called de Quervain's tenosynovitis, and that's tendonitis of the abductor pollicis longus and extensor pollicis brevis tendons. So those are these tendons out here, the ones that help kind of abduct and extend the thumb joint. So these ones out here. So sometimes these tendons become inflamed, again, maybe from video games and texting and things like that. They become inflamed and irritated. And then the person has pain when they like go to extend their thumb, go to do a thumbs up sign or something. The test is very simple. You basically have them create a fist where they put their thumb in the fist like this, and then you, as the examiner, ulnar deviate their wrist. You hold their forearm bones in place, and then you ulnar deviate the wrist joint. In other words, you're putting tension on these tendons. And if that hurts, if that exacerbates their condition, that indicates that those tendons might be inflamed, injured in some way. Where this gets a little confusing, where sometimes people put the wrong answer, is notice that the name of the condition is called de Quervain's tenosynovitis, but the name of the test that we just did is called Finkelstein test. So they don't really look like they go together. And you would think Finkelstein's tests for something called Finkelstein's disorder or something like that, but it's just how it is. So Finkelstein's test tests for de Quervain's tenosynovitis. And so just one of those things you just want to know just how they named the test. That's the doctor that came up with it. They named it after the doctor, and the condition is named after somebody else. I know. So anyway, just make sure you know that. So that covers a lot of the upper extremity stuff. The person that's here, any questions on anything before we go into the lower extremity? Oh. All right, well, then going into the lower extremity. So, again, just a reminder of the muscle bones that are relevant. So, first off, we've got the bones of the pelvis. So, you may recall, there's the three pairs of bones there's the ilium, ischium, and pubis, three bones on each side that make up the pelvis, and then they're all fused together. There's the pubic symphysis, where the two pubic bones, the one on the right and the left, come together. And Ren 2, remember, is located just superior to that pubic symphysis. And what sometimes comes up about the pubic symphysis is the pubic symphysis is pretty much the primary example of what we call a cartilaginous joint. So remember that most of the joints that we've talked about in like this review, most of the joints that we're talking about are synovial joints. They're freely movable. Some more so than others, but we have voluntary control essentially over moving them and they're freely movable. Then there's the bones of the skull that are more like suture joints. Like technically it's two bones coming together, but it's not really much of a joint. Like there's very minimal movement. They're sutured together really tightly. Cartilaginous joints are kind of like in the middle. They're semi-movable. Like they're not really freely movable, but there's a little bit of give, there's a little bit of flexibility. So, for example, like during childbirth, that pubic symphysis becomes a little bit more flexible to allow for delivery of the baby there. So you want to know that the pubic symphysis is like pretty much the primary example of what we call a cartilaginous joint in the body. And again, the idea is it's semi-movable, not freely movable like a synovial joint, but more flexibility than something like a suture in the skull. Then you might recall there's two openings, one on each side, one on the right, one on the left, that are referred to as the obturator foramen. These are openings in the pelvis. They're formed by a union of the pubic and ischium bones on each side. And those are basically big circular, like if you go to Trail Guide to the Body, you'll see these big circular openings in the pelvic structure. And those are the openings that are going to allow for the blood vessels, the nerves, the lymphatic vessels, et cetera, to pass from the torso to the lower extremity or vice versa, from the lower extremity up to the torso. So that's what those big openings are for. Allow the blood vessels, et cetera. Okay. See you later. So thanks for popping in. Good to sort of meet you briefly. Have a safe flight. All right. So we have the obturator foramen. Then there's a depression called the acetabulum on each side. And remember, the acetabulum is basically the equivalent of the glenoid fossa. So just like we had the glenoid fossa and the scapula that essentially received the humeral head to form the glenohumeral joint, or what we call the shoulder joint, this acetabulum on each of the ilium is going to receive the femoral head to form what we call the hip joint or the femoroacetabular joint, which is a little bit of a tongue twister. Femoroacetabular joint, or you could just say the hip joint. Now, similar to the shoulder joint, the hip joint is a ball and socket joint. It's freely movable. The joint can move in all planes of motion. It's not quite as movable as the shoulder joint. The shoulder joint, we tend to have a lot more flexibility, but it's similar in the sense that it can move in all the planes of motion and everything. So you want to know those, some of those key landmarks. Then, of course, we go down the femur. Again, not too much to say about the femur. I mean, because that's just very standard anatomy that will come up, of course, in your acupuncture channel studies. But, just a quick reminder, the femur, remember at the proximal part, we have a greater and lesser trochanter. Those are some important landmarks that are on the femur. At the distal part of the femur, we have a medial and lateral epicondyle, similar to just like the humerus. Then we go into the lower leg, and we're going to have the tibia and the fibula. Tibia more on the medial side, fibula more on the lateral side. And as we go down distally, the tibia will have that landmark known as the medial epicondyle. I'm sorry, not epicondyle, medial malleolus. And the fibula will have the landmark known as the lateral malleolus. And then just like we had carpal bones in the wrist, in the ankle joint, we have what we call tarsal bones. And the same kind of thing as I was saying for the carpal bones, you want to make sure that you can recognize the name of the tarsal bones and recognize that, if you get a question that says, for example, where is the cuboid bone located? You want to recognize, oh, that's one of the tarsal bones. So the answer is it's in my foot, it's in my ankle, as opposed to in the hand or in the skull or in the pelvis or in the spine. So make sure you just recognize those names: talus, calcaneus, cuboid, navicular, medial, middle, and lateral cuneiform bones. Because again, those are the bones of the ankle joint. And then the same thing as we were saying about the hand applies to the foot. Instead of metacarpal bones, we have metatarsal bones. Instead of, well, no, sorry, not instead of, we then also have phalanges. And same kind of thing as the hand. The big toe, that would be like phalange number 1, or if you're talking about the metatarsal that aligns with that, it'd be metatarsal 1. And then as you go out to the lateral side to where the baby toe is, that would be number 5. So same kind of thing. Again, the base is the more proximal part of those bones. The head is the more distal part of the bone. So the same thing we were saying about the hands. And as far as a few key standout muscles go, again, there's other muscles that'll come up a little bit in the O&E test, but just as far as a few highlights that don't really come up as much in the O&E test, you want to definitely remember the quadricep muscles. So remember, the quadricep muscles are called that because there's actually 4 muscles that make up the group. There's the rectus femoris, and then there's the vastus medialis, lateralis, and intermedius. And all 4 of those collectively make up the quadricep group. And remember, all of those muscles kind of converge to attach to the tibial tuberosity on the tibia. And when these muscles contract, they all collectively work to extend the tibia, or you can say extend the knee joint. So like a forward kick, like a front kick or something, or even just standing straight up, your tibia is an extension. Now, the rectus femoris specifically, so not the vastus muscles, but the rectus femoris specifically, that does one other thing in addition. The rectus femoris is a longer muscle. So that goes all the way up and attaches on your pelvis. So the rectus femoris also flexes the hip. So you picture like a marching pose, like stepping forward in a march, flexing the hip or flexing the you could say again, flexing the femur. So all of the quadriceps extend the knee, but the rectus femoris only. That one does also flex the hip. In other words, it's longer than the others and it crosses the hip joint as well as crossing the knee joint. The other muscles only cross the knee joint. And the nerve that controls the quadriceps is called the femoral nerve. So that's the nerve that's going to mostly innervate the front of the thigh. So that anterior aspect of the thigh will be innervated by the femoral nerve. Then, of course, on the back of the leg, we have the hamstring group. And the same kind of thing. It's a group of muscles. So there's three muscles that make up the hamstring group. There's the bicep femoris, the semitendinosus, and semimembranosus. The bicep femoris is more on the lateral side. The semi muscles are more so on the medial side. Basically, these are going to do the opposite of the quadriceps. So the hamstring muscles are going to extend the hip. So in other words, picture like a back kick or something, moving your femur in a posterior direction. And they're also going to flex the knee. So picture like heel to butt, kicking your own butt with your heel. The hamstrings are going to go the opposite direction, essentially, as the quadriceps. And this muscle or group of muscles is controlled by the sciatic nerve. So remember, the sciatic nerve, it's the longest, thickest nerve in the body, starts in the low back and then runs down the back of the leg all the way to the sole of the foot. And so that's going to innervate all the muscles at the posterior aspect of the lower extremity. It's going to control those muscles and it'll conduct sensation from those areas as well. Now, again, remember with this whole longest, thickest nerve in the body thing, make sure that you don't confuse it with the vagus nerve. Remember that the vagus nerve is the longest of the 12 cranial nerves. So, of the 12 pairs of cranial nerves, the vagus nerve is the longest of those. But the sciatic nerve is the longest, thickest nerve in the entire body. And sometimes, people get those confused. So, in other words, if you get a question, what is the longest nerve in the body? And vagus nerve and sciatic nerve are both listed. Again, it's not a trick question. I mean, the answer is sciatic nerve, period. Sciatic nerve is longer than the vagus nerve. Again, just the vagus nerve is the longest of the cranial nerves. And just make sure you know the muscles that make up these groups. So make sure you know, for example, the vastus lateralis is one of your quadricep muscles, and the semimembranosus is one of your hamstring muscles, because sometimes they could make a question, they meaning whoever writes the questions, can make a question seem like it's a harder question, seem like it's asking about something obscure when, oh, if you realize, oh, wait, the vastus medialis, that's one of my quadricep muscles, or the semitendinosus, that's one of my hamstring muscles. If you know that, then you know what the muscle does. But you will get a lot of people that like have no idea what the vastus lateralis is or have no idea what the semimembranosus is. So if you phrase the question like, what's the action of the semimembranosus? They're like, oh no, I didn't study that muscle. I don't think I know. But if you recognize, oh, that's one of the hamstring muscles or that's one of the quadricep muscles, then you should know what it does. Okay. Then we have the calves, the gastrocnemius and the soleus. Remember, the gastrocnemius is the more superficial muscle, and the soleus is deep to that. And those two muscles collectively cause plantar flexion. So, like standing on your toes, plantar flexion of the ankle, or you could say plantar flexion of the foot, standing on your tippy toes, kind of thing, pointing your toes. And then we have the tibialis anterior. That's gonna be like where your stomach channel is located. It's gonna be lateral to the tibia on the anterior side. And when that muscle contracts, it's gonna do the opposite. It's gonna do dorsiflexion of the ankle. So that's like walking on your heels or pointing your toes and your feet towards the sky. And it'll also do a little bit of inversion of the ankle. Remember, inversion is where your feet turn in towards midline. Eversion is when they go out the other way. So this will do inversion of the ankle joint or inversion of the foot along with simultaneously dorsiflexion. Right. So these are some of the key muscles here, muscles, bones. And then we have a few orthopedic tests, a few O&E2 tests that we'll talk about. But we are about an hour in. I need to take a quick break myself. So rest my voice and get a drink and stuff. So let's take 10 minutes and then we'll pick up here when we get back. So you all obviously can just jump 10 minutes forward. But like I've said before, I don't want to risk stopping the recording and forgetting to start it again. So just jump 10 minutes forward. All right, everybody, let us continue here and probably wrap up. I mean, we'll see. Excuse me. All right, so the last thing we have left are some of the orthopedic tests for the lower extremity. And notice there's not as much writing on these, not because I like got lazy and just stopped, but because just for whatever reason, like these few exams for the lower extremity, it's like not really too much comes up about these conditions because like they're fairly broad brushstrokes. So it's more just like just know this test goes with this condition, and that's pretty much it. So first off, again, you can see pretty broad brushstroke. Sacroiliac joint dysfunction slash hip pathology. In other words, there's some kind of, either jamming or irritation, arthritis, tightness, etc., in the areas around where the sacrum and the iliac bones meet up, the sacroiliac joints, or the hip joints themselves. So usually it's more like there's tightness, decreased range of motion, just in those general areas. A lot of people, their hips are just very tight. So not really much comes up with these, just other than knowing there's some type of like general tightness, dysfunction in those areas. And you just want to recognize that there's three tests that are said to go with this. There's Hibbs test, knee to shoulder test, and what they call the Patrick Faber test. The Patrick Faber test is the one where you might remember you put the lower extremity in sort of a figure four position where the femur is abducted a little bit, the knee joint is bent, and the ankle is resting on the opposite knee, and the person's sort of in like a figure four type of position. And oftentimes, if somebody has hip dysfunction, it's like that that bent knee can't really like rest on the table. It's like, popped up. Basically they can't relax it. And again, you could easily look up a picture of a Patrick Faber test. It's hard to describe, and unfortunately, with the camera, it's hard for me to show you my leg. Um, but basically, it's like they have difficulty holding that position. They have difficulty relaxing their leg. You just see like the muscles and everything are really tight. But honestly, for comps purposes, there's really not much that comes up with these. Just make sure you know these tests. If you're told that any of these tests are positive, that indicates just some type of general sacroiliac joint dysfunction or hip pathology. Again, very general, very broad brushstroke. Same kind of thing here. Tight rectus femoris. So sometimes you'll have tightness in the rectus femoris muscle, and as a result, that can pull them into an anterior pelvic tilt. That can cause them to feel some kind of, pain, tightness in the upper thigh area. So there's usually just sort of very general, vague signs and symptoms like that. Not really too much comes up with this, but there is a test called Thomas test. This is the one you may recall where the patient would be sitting on the edge of the table. They would be pulling one of their knees like up into their chest, and they would let the other leg hang off the table. And if they have tight rectus femoris, what's going to happen is the leg that's hanging off the table, it's not going to really hang off the table very easily. It's going to kind of naturally go up towards their abdomen. They're going to have trouble just relaxing it off the table because, again, it's so tight. So they call that Thomas test. And again, comps wise, it'd be one thing if you had to perform these, we'd probably go in the classroom and practice them or something as part of the review course. But you just have to recognize for comp purposes that if they say something about Thomas test being positive, that indicates tight rectus femoris. That's it. Don't really go too much beyond that for these. Then you probably recall there's ligaments surrounding the knee joint, essentially holding the tibia and the femur in alignment with each other. And there's a ligament along the medial side. We call that the medial collateral ligament. One along the lateral side. We call that the lateral collateral ligament. And then there's two ligaments that kind of crisscross each other within the knee joint. And those are meant to support and prevent against excessive anterior or excessive posterior movement. We call those the anterior and posterior cruciate ligaments. Make sure you remember collateral and cruciate and which ones go with which. That the medial and lateral, those are the ones that get collateral. Think of like lateral, collateral rhyming. And the ones for the anterior posterior direction, those are the cruciate ligaments. Now, essentially, if one of these ligaments is injured or torn, you're going to get excessive movement in the direction that that ligament is supposed to support, in the direction that that ligament is supposed to prevent excessive movement. So, for example, if somebody has the medial lateral ligament, medial collateral, medial collateral ligament torn, if somebody has that torn, what's going to happen is that the tibia is going to move in a more lateral direction. You're not going to get that support on the medial edge of the tibia to prevent it from angling out laterally. We call that a valgus position. And the other side of that coin is if the lateral ligament is torn, it's going to fail to prevent the tibia from moving in a medial direction. It's going to fail to sort of hold it to that lateral side. And the tibia is going to start to move in a more medial direction. We call that a varus position. Because remember, normally the tibia shouldn't really go laterally or medially at all. It should be pretty much a straight line. So, of course, as an examiner, you could create this situation in a controlled environment. Like you can test the ligaments by supporting the femur and then pushing the tibia in either direction. You shouldn't really get any movement. But if you do get movement of the tibia in one direction or the other, as we said, if it moves in a more lateral direction, that's what we call a valgus position, and that would indicate a medial collateral ligament tear. If the tibia moves in a more medial direction, that's a varus position, and we would say that indicates a lateral collateral ligament tear. So essentially here, you just want to know which goes with which. Valgus goes with medial lateral collateral ligament. Medial collateral ligament. So valgus, if the valgus test is said to be positive, the answer, the diagnosis would be that there's most likely a medial collateral ligament tear. If the varus stress test is said to be positive, or we say that the tibia moves in a varus direction or varus orientation, then that would indicate the lateral collateral ligament is torn. So you want to just here know which one goes with which. Valgus versus varus, which goes with which. And then for the anterior cruciate and the posterior cruciate ligaments, this is where you do what we call anterior and posterior drawer test. And this is the one where you have the patient laying on the table in a supine position. You have their hip slightly flexed and their knee slightly flexed and their foot placed on the table, one leg at a time. So they're kind of like in a bent knee position with their foot resting on the table. And again, hopefully you can kind of follow the descriptions because, again, this is a review, right? You're supposed to already basically know what this test is, and this is just a reminder. But if you've completely forgotten these things, then, it's easy to just go to YouTube or something and look up anterior drawer test. But then what you as the examiner does, they're in this position. You as the examiner grab their tibia and pull it towards you. Try to move their tibia in an anterior direction. Really, there shouldn't be much movement. There should be very minimal movement. The tibia and the femur should be held together pretty tautly by these ligaments. But if you do get a big shift, if the tibia is moving in an anterior direction towards you, if you're like you're able to do this with the tibia, then that would indicate an anterior cruciate ligament tear. So if the tibia moves anteriorly relative to the femur, that would indicate an anterior cruciate ligament tear. That'd be a positive anterior drawer test. And posterior is the same principle. It's just if the tibia is able to be pushed posteriorly relative to the femur, that would be a positive posterior cruciate ligament test, and that would, or a positive posterior drawer test, and would indicate a posterior cruciate ligament tear. So remember, with ligament tears, it's more about instability. It's not necessarily painful unless it's an acute injury. But sometimes people have tears from long ago and the inflammation and everything has subsided, but they just have this lingering instability at the joint. So keep that in mind. This might not be painful. It could be painful if it's an acute injury, like an acute tear, then it would definitely be painful because there'd be a lot of inflammation. But if this is something that, whatever caused it happened a long time ago, and they're just kind of noticing some instability, that might be what the patient comes in with. They might come in and say like they feel like their knee joint's giving out or something. And then you do these tests and you realize that they have some kind of deficit of their one of these ligaments, whether it's a total tear or a partial tear. And then you might recall there's the connective tissue that's on the base of the tibia that kind of holds the femur in alignment. It creates a little depth and it allows the condyles of the femur to sort of um, pivot or kind of roll. Roll is probably the best word, kind of roll along the top of the tibia. And it kind of helps hold them in alignment, provides a little support system for those condyles to roll. And sometimes what happens is that connective tissue, known as the meniscus, tears. And usually the way that presents is if the meniscus is torn, the patient will complain of like some kind of like catching sensation. Like when they move their knee joint, it doesn't move smoothly. They feel like something catching or something clicking, or that's usually how they describe it. And it could be painful as well. Again, depending on the amount of acute inflammation going on, it could be painful, but they often include that detail about some kind of catching or clicking. And the test that you do is what they call McMurray's test. This is where you, as the examiner, pick up the lower extremity, you support the femur and the tibia, and you kind of like move those bones in sort of like circular motions, just trying to go through all planes of motion. And you yourself are just sort of assessing, like, are you feeling like any kind of catching or clicking? And if so, that would indicate a meniscus tear. It would be a positive McMurray test indicating meniscus tear. Then we have a lateral ankle sprain. So that's where the ligaments on the lateral aspect of the ankle joint are torn. Now, you might question why specifically lateral ankle sprain. Remember that when you sprain the ankle, it's much more commonly a lateral ankle sprain, just because of the way we stand, the way we walk, the fact that like to roll your ankle medially kind of requires you to like fall into your other leg in a way. And that's just harder to do. It's much more easier to roll it laterally. That's much more likely to happen, much more easily happens just based on, the joint dynamics and everything. So it's just a much more common injury, a lateral ankle sprain. So usually the patient, again, if it's an acute injury, it might be swollen and painful. If it's more like something that happened a while ago and now they're just kind of noticing like some instability, it may not be painful. And the two tests are very similar to what we were talking about with the knee joint. So there's the anterior drawer test. Here, though, it's a little bit different. What you do is you have their foot hanging off the table. So you have them kind of pushed up towards the front of the table with their foot hanging off. You support the tibia and the fibula with one hand, hold it on the table, cup the calcaneus with the other hand, and you kind of do this type of thing. And there really shouldn't be much movement, right? I mean, these bones should all be held together if the ligaments are all intact. But if the calcaneus and the bones of the foot are kind of like, if you're getting a lot of movement, that would indicate a tear in the ligaments. That'd be a positive anterior drawer test of the ankle, indicating a lateral ankle sprain. And then the other way you could do it is you can, same kind of thing, support the tibia, the femur, cup the calcaneus, or kind of hold the foot as a whole, and move it in medial lateral motions. And if you're noticing that the joint moves too far medially, that would indicate a lateral ankle sprain. That's what they call the Talar tilt test. Now, remember, there should be some medial movement. It is normal that the ankle joint can move medially. But if you're getting excessive medial motion, and that's just one of those things that you do enough of these, you get a feel for like what it should do versus what's too far. You'll kind of know like, okay, this is coming out of alignment. This is going further than it's supposed to. That'd be a positive Talar tilt test, and again, indicating a lateral ankle sprain. And again, I'm kind of going through some of the description to just to recap and remind you of these disorders and these tests and stuff. But again, for comp purposes, this does not get overly technical. So like don't worry if like every single because some of it like again I can't it's hard for me. I can't put my foot up here and show you exactly. So I'm doing my best to just sort of orally describe it. Don't worry if you're not catching like every little detail or envisioning like precisely how you do it because you're not having to perform it. You just want to make sure at the end of the day that you recognize these are the conditions you need to know. These are usually the symptoms the patient complains about. This is the test you use. This is the name of the test. So if this test is positive, it indicates this condition. And then, maybe very brief, generalized descriptions of how you do the exams, but like nothing overly technical. And then lastly, we have what they call Morton's neuroma, or could indicate a foot fracture. Now, Morton's neuroma, you may recall, is basically a growth, like a little mini tumor around the sheath of the peripheral nerves that go between the metatarsals of the foot. Now, you can get a growth like this in other areas, but Morton's neuroma specifically is when it happens in the foot. So the person complains of pain in the dorsum of the foot. It's usually worse when there's any kind of tightness around the foot because that causes compression of this neuroma. And the test is just simply what they call Morton's test. Squeeze the foot. Nice, easy one. Squeeze the foot. That elicits pain. That can indicate a Morton's neuroma. Now, that can also just indicate a foot fracture. Typically, we think of this test as assessing for Morton's neuroma, but one thing you have to have in the back of your mind is like, well, maybe they have a fracture in their foot, and that's why it hurts when I squeeze it. So the point is that there could be things like a foot fracture that trigger a positive result, things other than a Morton's neuroma. So it might need require an X-ray or something to confirm. But nice, simple one. I love how they end ONE2. If you kind of go in order here, they end ONE2 with this nice, super easy test. All right. And then lastly, there's not really an orthopedic exam for it, but I have seen questions come up about basically what plantar fasciitis is, and I don't think anybody will have any trouble with this one. This is where the plantar fascia becomes really tight and inflamed. And so it basically hurts when they walk, when there's any kind of stretching on the sole of the foot, it can hurt. It's usually worse, when they first get up in the morning, but it's better with stretching and movement and circulation and all that. But again, there's really nothing else you would confuse this with. So on an exam, if you see a description like this, really the main thing is just don't think it's like a trick question, like go with the obvious answer. All right, so that is all of the muscle bone stuff. Now, notice this is a pretty big handout, and there are quite a few questions in the test bank on this. So, I mean, it would not be surprising if out of 60 questions on the bio exam as a whole, it would not be surprising if, you know, 15, 18 of them were from this handout. It doesn't mean they necessarily will be. Like, again, it's a random selection of questions from the test bank, but it wouldn't be surprising. So this is a handout you want to make sure you know pretty well. All right. All right. So at this point, we've basically covered all the major topics. So just to recap, like kind of an overview of the exam as a whole and what we covered. There is the Chinese medicine theory section that you'll have 60 questions on the Chinese medicine theory section. That we pretty much all covered the first day of this review course, because you might recall we had said that's basically the exact same content that you're studying as was on the first year Chinese medicine theory section. It's not necessarily going to be the exact same questions, but it's the same general material, same general content you're being tested on. So essentially for that, I just gave you all the same handouts that you received for the first year comp. And I was like, review that again. And the first day, we kind of highlighted some of those things, the first day of the review. So all of those handouts that you got for first year that you studied, study those again, make sure it's fresh in your head. Most people pass, huge majority of people pass the Chinese medicine theory section for second year ends. It's not unusual for every single person to pass. And if there are some people that don't pass, it's not unusual. That's like maybe 2 or 3 people out of like 80 people. So again, most people will do fine as long as you review like those key foundational details. Then there was the acupuncture section. Again, 60 questions, acupuncture section. Now, we had said that approximately three quarters of it, 75%, is all the same stuff for first year comps: point locations, point categories, channel pathways, point functions, again, all the same stuff. So I gave you all those same handouts that recap, the lung channel pathway and go over point locations and go over the point categories. Again, that stuff you just gotta go over it again and again until you know pretty well. But again, you're all here taking second year. You already passed it first year. You should know most of the answers to those questions that come up. Then the stuff that's uniquely second year, it's maybe only 25% of that exam section. There's going to be some questions on the extraordinary meridians, maybe about 12 questions or so. And we went over that during week 2 of the review class. We went over the Chong and the Yang Chao, the Yin Chao. So make sure you recap that, particularly paying attention to like what are those crossing points on those extraordinary channels? What are the master couple points on those extraordinary channels? And why would you use one extraordinary channel versus another? So like that's like knowing things like use the Chong meridian for blood disorders, for example. And then we said there was a little bit of auricular. And we had said that the auricular mostly focuses on landmarks of the ear and which landmarks certain points are located in. So most of the questions with auricular just have to do with knowing, for example, the spleen point is in the cavum concha, the kidney points in the symboconcha, the eye point is on the ear lobe, and so on. The upper extremity points are in the scapha, that kind of stuff. Mostly focusing on that because remember, functions, I mean, most of the point names tell you what they're used for, right? I mean, if there's a point called the wrist point, you use it for wrist disorders. There's really not too much to say about the functions. So a lot of it just comes down to like recapping those landmarks on the ear and what points are located in those landmarks. So we had a class where we summarized which ones to really focus on. So acupuncture, we got that. Then we have bio. Bio, we had said that has the most uniquely second year stuff. That's why we did go over that thoroughly. And all the handouts are self contained. So sometimes people have asked, do I have to go back to my first year bio notes and look at those? No, you don't, because like all of the relevant anatomy physiology is already in the second year handouts. Like today when we were going over all the ONE2 stuff, we recapped the bones and the muscles, and that's all the stuff from the first year handouts. So it's already baked into the cake. So we have that stuff we covered pretty thoroughly. Like there's no reason that you shouldn't do well on the bio section if you study it. But that section's the section that has the most uniquely second year material. Then there's the lawn safety section. That again is the same universe of material that you would have studied for first year. So it's the same handout that I gave you for first year, just telling you to go over it again. And remember, that's going to mostly cover things like clinic policy. It's going to cover things like certain laws and regulations like HIPAA. It's going to include some things about like cautions for treating patients, like universal precautions and the definition of cross infections and things like that. But again, you already passed that on first year. It's really the same universe of material that you're just being tested on a second time. All right. So if you passed first year, you should have no problem passing here. The only thing is with second year, it's only 10 questions. So if you make 4 silly mistakes, that's enough to cause you to not pass. So just make sure that you read the questions thoroughly and that you're going with the most likely answer based on what you know. All right. Herbs, that's separate. Most of you would be doing that a following term, and the herb only review covered that. So the only thing we have left now is the case study section. And that's what we'll go into a little bit right now. Now, the case study section, I mentioned the very first day of this review class. The case study section is really a hodgepodge of everything else. So there's not really any unique case study content to study to look at. Like it's not like there's a particular class where like, oh, this is the case study class, so study this, or this is unique material, that's case study material. It's just sort of a hodgepodge of everything else. So in one exam, you're going to get case study scenarios and you're going to be asked like, what pattern do you think the patient has? What tongue would you expect? What pulse would you expect? Well, that's all Chinese medicine theory stuff. But then you might get asked, what acupuncture points would you use for this patient? Well, that's acupuncture material. You might get asked, what biomedical diagnosis do you think this patient has? Well, that's biomedical stuff. So again, it's a hodgepodge of everything. So if you studied all your other stuff, you should be pretty prepared for the case studies. But that being said, we'll kind of go through and highlight some key things. All right. So in total, there's 70 questions. Generally, it breaks down that, and ignore the fact that it says the first 50 versus the remaining 20, because now that it's online, the questions do shuffle. So it used to be that like there was a certain order, but now they do shuffle. But the bottom line is about 50 of the questions are typically related to like full case studies. But mixed in, there's usually 20 questions that are just sort of like quickie standalone questions, something simple like what color tongue would you expect with summer with stomach heat? And then the answer is red. That's it. Move on. Takes 10 seconds to answer that question. So, and in other words, mixed in with these, there are some quicker questions. So generally there's plenty of time. Don't worry too much about time. But here's basically the breakdown of the case studies. So you'll get a case, and then each case can have anywhere from like 1 to 3 questions based on it. Now you might panic a little bit of like, wow, that's a lot of reading. If there's only one question for a case and then the next question's another case, God, that's a lot. But these are very quick cases. Like most of these cases are like 2 or 3 sentences. In other words, very to the point, key information. It's not like your diagnosis and treatment of disease courses where you might get a case that's like a whole page long and it's giving you every detail about the patient's family history, their social life. These case studies on the comps are usually like very to the point. 2 or 3 sentences tells you, their age, their sex, their chief complaint, a few key symptoms, their tongue and pulse, kind of gives you those key things, 2 or 3 sentences. That's it. And here are the main kind of questions that you tend to be asked. So for those cases, the most common question is what's the TCM pattern? That's the one to really know. So make sure that when you're studying for your Chinese medicine theory section, that you're also kind of retaining that information for the purpose of your case study section, because that is the most common question. What pattern does the patient have? And you need to know the pattern sometimes, even if that's not what they ask, because sometimes they might just ask, like, what tongue would you expect this patient to have? Or what points would you use? Well, in order to answer those questions, you have to know the pattern. You have to know that, oh, this patient has a stomach heat pattern, so I suspect their tongue would be red. Oh, this patient has a stomach heat pattern, so I would use a point like stomach 44 to clear stomach heat, and so on. So you're always having to answer what the pattern is, even if that's not what the question is asking for exactly. You still have to kind of know it in the back of your mind to answer what is being asked. One thing to be careful about is, and I can't emphasize this enough, that's why I highlighted it. Do not let the Western diagnosis in any way influence your choice of pattern. Sometimes they will tell you in the case, a 32-year-old male with a history of whatever it might be, with a history of asthma or a history of hepatitis B, whatever it might be, don't let that influence your choice of pattern in any way. Because remember, Chinese medicine, we're looking at their signs and symptoms and deciding from a Chinese medicine perspective, what pattern does that fall into? So, in other words, just because somebody has a hepatitis from a Western biomedical point of view doesn't necessarily mean they have a liver pattern from a TCM perspective. You know, jaundice, for example, where the person has a yellowish discoloration due to, say, hepatitis from a biomedical point of view, in TCM, we might look at that as accumulation of dampness due to spleen deficiency. Again, it just depends on the signs and symptoms. So if the person's signs and symptoms are things like loose stool, fatigue, they have a yellowish discoloration, um, they have a pale tongue, that kind of thing. If their signs and symptoms sort of match, like you go like, all right, well, that looks like spleen chi deficiency with damp accumulation. You don't just automatically go, oh, they have liver heat because the person has hepatitis from a biomedical point of view. So make sure that that's something you're really clear about. Mhm. Another example I put here is maybe the person has anemia from a biomedical point of view, but if you think of the symptoms of anemia, sometimes some person with anemia might have shortness of breath, they might have fatigue, they might have a weak pulse. We might say that that looks like lung qi deficiency. That might be their pattern from a TCM point of view, just depending on what symptoms they give you. Now, maybe they also have blood deficiency from a TCM point of view, because they might also be pale or something. So, I mean, they could have both, but again, don't just automatically assume anemia means blood deficiency. Mhm. Sometimes they ask about the TCM disease. So those are things like they're not patterns per se, they're not Zongfu patterns. Those are things like wasting and thirsting disorder, restless organ disorder. Now, there tend to be very few questions like that, but there are a couple. So, like, if they're talking about somebody that has, polyuria, they're urinating a lot, they're really thirsty, and every time they drink, they're urinating it out, they're losing weight, they might ask about what TCM disease does that sound like? And that could be something like wasting and thirsting disorder. The tongue and the pulse. Sometimes in the case, they'll give you the tongue, but not the pulse, or vice versa. They'll give you the pulse and not the tongue, and they'll ask you for the other one. They'll give you a case, chief complaint, signs, symptoms. Maybe they give you the tongue or they give you the pulse, and then they ask you what you think the missing one would be. So, for example, if a person has a slippery pulse and they have other signs and symptoms of damp accumulation and they ask you what tongue you would expect, you might suspect that it would be like a pale tongue with a greasy white coating, because greasy white coating typically indicates some kind of like damp or damp cold accumulation. Or vice versa, they give you this tongue and they maybe also give you some signs and symptoms like distended abdomen, diarrhea, and they ask you what pulse you would expect. And if you're thinking they have damp accumulation, then you'd probably assume they have a slippery pulse. Now, again, all of that stuff just goes back to studying the same notes that you're studying for the Chinese medicine theory section. There's a handout I gave you of the various tongues and pulses and patterns. Just know that stuff well for the Chinese medicine theory section. Also know it for here. Then they ask you sometimes about the treatment principle. Now, the treatment principle, this is one usually on a multiple choice. It's one thing if you had to write it out of thin air and you might think like, oh, how do I phrase this exactly? That might be one thing. That might be a little bit challenging in some cases. But in a multiple choice, go with what's obvious, right? If you're looking at this patient as having some kind of heat pattern, one of the options is clear heat, don't overthink it. They have Xiaoyang disharmony, and one of the treatment principle options is harmonize the Xiaoyang. Again, don't overthink it. So, yeah, most of the treatment principles just kind of make sense based on the pattern. If they have qi stagnation, you need to move qi. If they have blood stagnation, you need to invigorate blood. If they have liver qi stagnation, you move qi. Maybe another option, maybe along with move qi, it says harmonize the liver, something like that. They have a heat pattern, you clear heat. They have a cold pattern, you warm the middle jiao or dispel cold, something like that. So most of the treatment principles just kind of make sense. They have an external wind attack. You release the exterior, expel wind. Then they ask sometimes, what points would you use for this person, for this patient? What point combination would you select? Now, here's where the question sometimes comes up, where students ask, do I need to study all the notes, all of those cards that I got in the point combinations class where it listed like every pattern and every point combination? And I'm going to give you an answer that's like, you know, kind of up to you. Like, depends. Depends on you know yourself as a student and like kind of what you need and what you don't. Some people are like, no, I will panic unless I know the answer for a fact. Like I have to just have it memorized. I have to have a certain correct answer memorized or I'll panic. If that's you, then sure, go to your point combinations class notes, memorize all the combinations. And so that way you'll have like sort of a for certain, for sure answer on any questions about what point combination you might use for a certain pattern. That being said, personally, like I said, I've looked at the exams many times, particularly when students don't pass, and I kind of take a look to see where they went wrong. 90 plus, like 95% of the time, the correct point combination is pretty clear. Like I'll be honest with you, I don't have all those point combination class combos memorized at this point because in real life, like you're not performing memorized point combinations. You're treating every patient as an individual and people have different combinations of things going on. So very seldom in real life are you just like performing those pre-memorized point combinations. So at this point, I don't have those memorized anymore. But yet when I look at the exam, it's pretty clear to me like what the correct answer is in over 90% of the questions because the wrong options typically include some points that just don't make sense. So here's just an example. If you assume that the patient, let's say the patient has in the description, they have low appetite, loose stool, fatigue, um, maybe easy bruising, they have a pale tongue with scallops on the side, they have a weak pulse, and you're like, okay, sounds like spleen sheet deficiency. Well, the correct option contains points that make sense for that pattern, right? Spleen 3, it's the source point of the spleen used to regulate, tonify that organ. The UB20, the back shoe of the spleen, same kind of thing. REN 12, remember, is the influential point of Fu organs. So it's just an overall good point for digestion in general, because most of your Fu organs are digestive organs. And of course, stomach 36 is just an overall big point for boosting qi throughout the body and particularly benefiting spleen qi. So, like all of those points, that would be an example of a combination that could be a correct answer here, that those points should all make sense. And then wrong options might include like one of those or some of that, but they're always going to include points. They're like, well, why are they including those? Like maybe the wrong options include like kidney 3 or something. And you're like, well, why would you use kidney 3 for spleen sheet deficiency? Or it's including like, you know, liver 8 or something like that. I'm like, well, liver 8, I mean, isn't that for tonifying liver blood? Like, why would you include that for spleen sheet deficiency? So, like, the wrong options are generally including things that just don't fit the pattern. And don't overthink it. Like, generally speaking, like, again, you in the back of your mind, even if they don't ask for it, have to assess what pattern am I treating? And then look for the combination where the points best match that pattern. And don't think too out of the box. Like, don't try to justify points that don't really make sense. Don't go down this road of, well, but gallbladder, I mean, that connects to the liver. And then if somebody has liver cheese stagnation, that could affect spleen function. And then, so, okay, maybe I'd want to do gallbladder 14. Like, they're just go with what's in front of you. If the only thing you know is this patient has spleen sheet deficiency, then you should be selecting points that treat spleen sheet deficiency. Don't be making assumptions of like other things that they could have going on and try to somehow justify using some other random point. So if you keep that in mind and you do that, you'll find that most of the answers have a key standout correct answer. And all of the wrong options, there's something in there that just doesn't really make sense. So again, up to you whether or not you want to really memorize every combination or you want to just trust that at this point you know your point functions, you know your point categories, and you could kind of reason out that these points would be best for this pattern and those points would be best for that pattern. Then sometimes you'll get asked questions about what accessory techniques would you use? Like, would you do moxa? Would you do cupping? For those, again, also think pretty big picture. It doesn't tend to get very nitpicky. So basically, if the person has a cold pattern, yeah, maybe you would moxa those points. And sometimes that's how they'll list it. Maybe they'll even combine number 5 and number 6 here, where maybe it will say, like, for example, moxa UB20 or something like that. Like it'll list points and it'll say moxa these points or do these points without moxa. And, basically, if it's a cold condition, yeah, go with the option that says to moxa the points. And if somebody has an exterior attack, that's where you might do cupping. You could also do cupping with chi and blood stagnation because cupping is kind of moving, invigorating for the chi and blood. It also can kind of pull pathogens out. Gua sha is kind of similar. You could do that to release the exterior. You could do it to break up chi blood stagnation. So most of those accessory techniques, I mean, first off, there's not a ton of questions on those, but there is a handout that I gave you that is labeled Acu techniques, and it kind of goes through these different techniques. Just basically apply what's on that handout. Know what you use the various techniques for. And if you're treating such a pattern and it's asking you what accessory technique you might use, yeah, go with that answer. So, yeah, if you're treating somebody with chi and blood stagnation, you may do cupping over that region. Then they sometimes ask, what is the most likely biomedical diagnosis? Now, I'll tell you, as far as the case study section goes, usually the biomedical diagnoses are like really big picture obvious. They tend to not be very nitpicky at all. So, like, for example, a person that's been smoking for 50 years with a chronic cough, and like the right answer is COPD. Something like, again, relatively obvious. But again, if you study your biomed handouts and you know the key conditions we go over for the purpose of the biomed section, you should have no problem answering the case study questions that are biomed related. Because if anything, I think the case study ones are even more like broad brushstroke. And then the last of the most common types of questions you get in the case study section, and some just be a little careful with. Like it's very easy in some ways, but it's something that sometimes people make mistakes with. Is they sometimes ask you what kind of lifestyle modifications you would advise. The thing to just be careful about is sometimes students will pick just things that they think of as generally healthy that are good for everybody, rather than picking the selection that matches the pattern the person has, which again is why you always have to take into account what is the pattern that I'm treating. Even if they don't ask you for the pattern, you always have to take into account like what pattern does this patient have and pick the lifestyle modification that matches that. So in other words, if somebody comes in and their chief complaint is diarrhea and it's like the diarrhea has pus and it's burning and it's bloody and they have abdominal pain and various things like that, and they have a slippery rapid pulse and a red tongue with a greasy yellow coating, and you're thinking, okay, this person sounds like they have some kind of damp heat accumulation. Well, then your lifestyle modification should be they should avoid foods and things that might exacerbate that. They should avoid like greasy, spicy foods. Not that you should tell them they need to get more sleep. Not that you should tell them they need to exercise. Not that you should tell them they need to meditate. Now, again, those things might be generally good advice for everybody, but they don't fit the pattern of this person. So, like, again, the answer you should select is not what you think is the most generally beneficial thing. You should select the answer that matches the pattern you're treating. So, in other words, specific dietary modifications, not telling them to get more sleep at night. Now, if they come in with chi deficiency signs, if they have a weak pulse and they're tired all the time, and okay, well, in that case, maybe more sleep would be a good recommendation. If they come in with liver chi stagnation signs, somebody with a lot of mental emotional stress, hypochondriac pain, they're holding their breath, they have a wiry pulse, Okay, then maybe meditation, might be a good thing. But again, just make sure you're selecting what fits the pattern. Now, a couple other bits of general advice here. If there's a question and answers where there is an answer that is somewhat seemingly obvious, it definitely seems to match the case more than the other answers. Don't overthink it because it's not worded exactly the way you would think it should be worded. Keep in mind with multiple choice, it doesn't have to be the most perfect answer. It's just got to be the best of the options provided, the thing that's the best match of the four options. So it doesn't have to be exactly the way you might have worded it. So I gave you an example here. Let's imagine somebody comes in with a chief complaint of diarrhea. And it's diarrhea that, as you get more information, it's diarrhea that's watery, there's undigested food in it. It's worse when they eat cold foods. You palpate their abdomen, it feels cold. Their pulse is maybe deep, forceless. And you're thinking, sounds like spleen yang deficiency. Yeah, it definitely makes sense. It does sound like spleen yang deficiency. You look at the options. Spleen yang deficiency is not a choice. Some people are going to immediately go into panic mode, but read the options because sometimes there's an option where, even though it's phrased a little bit differently, it's basically the same thing. Like the two overlap in some degree to some degree. So, like for example, maybe the option says middle jiao deficiency. Well, the spleen is one of your middle jiao organs. Yang deficiency is a type of deficiency. So maybe that answer is a little more broad than what you were thinking. You were being a little more specific and you were saying spleen yang deficiency, and this answer is a little more broad brushstroke. But if there's no other answer that is better, then yeah, spleen yang deficiency is under the umbrella of middle jiao deficiency. So those two things are not mutually exclusive. So, I would go with that. Another thing to be careful about, make sure you look at the complete answer. I see students do this all the time, like even on like my take home quizzes, I see students do this sometimes. And sometimes a part of an answer is correct, but part is not. So I gave you an example here. Let's say that somebody comes in and they have hypochondriac pain. It's red, it's burning, it's maybe there's little pustules in the area, like maybe how shingles might present, for example. Maybe the person has like red burning eyes with discharge. Maybe there's even some sores around the genitals because remember, liver channel wraps around the genitals. Maybe there's some discharge as well. And so you're thinking it sounds like they have damp heat in the liver and gallbladder channels, based on the distribution and based on the signs. You're thinking they have damp heat in the liver gallbladder. So let's say you go look at the answer options now, and option A looks like, oh my God, exactly what I was thinking. It says damp heat in the liver gallbladder channels. But then it continues on and says with kidney insufficiency. And you're going, huh, well, liver gallbladder, damp heat, that's kind of what I was thinking. But I mean, kidney insufficiency, I don't know. Where's that? Don't don't start finding ways to justify kidney insufficiency if the case doesn't really give you any signs of that. So let's say option B says damp heat in the liver channel, just kind of plain damp heat in the liver channel. It doesn't mention the gallbladder channel. In that kind of scenario, I'd go with option B because keep in mind, right? If somebody has damp heat in the liver and gallbladder channels, it would still be accurate to say they have damp heat in the liver channel, because they do. They do have damp heat in the liver channel. Maybe you would have also said gallbladder if you were writing an answer out, but it's not wrong to say they have damp heat in the liver channel. But it is wrong to say they have kidney insufficiency because there's no signs of that. There's no signs of kidney insufficiency. So if there's no like low back pain, knee pain, there's no night sweats, there's no 5 center heat, there's no mention of like scanty dark urination, then yeah, don't pick an answer that has kidney insufficiency in the mix. So again, something to just be careful of. Don't always pick the more inclusive answer. Make sure that the case supports what you're selecting. Can't emphasize that enough. And remember, above all else, If you're ever in a situation where like the signs and symptoms are maybe a little bit confusing and you're like, I don't know, I mean, fatigue, that could be a lot of things. I'm not really sure. Like maybe it's this, maybe it's that. Above all else, make sure the answer that you're selecting matches the tongue and the pulse. You've heard that a million times probably, but I can't emphasize it enough. Make sure your answer matches the tongue and the pulse. They are not going to give you an answer on the comps that contradicts the tongue and pulse. Now, in real life, we know things aren't always so neat. And sometimes in your diagnosis and treatment of disease classes, your instructors purposefully come up with complicated cases just to, facilitate dialogue and have you think and have you analyze more. But on the comps where you have to select like one absolutely correct answer, and if you don't pass, you have to retake it, they're much more friendly. They're not going to give you an answer with the tongue on the pulse somehow contradict the answer. So if there's like a red tongue with a peeled or scanty coating, thin rapid pulse, your answer should be something with yin deficiency. Whether it's kidney insufficiency because they have low back pain and scanty urination, or whether it's lung yin deficiency because they have a hoarse voice and a dry cough, your answer should be something with yin deficiency if you're seeing that kind of tongue and pulse. Make sure you review your pulse locations because this is actually, yeah, it's one more thing you have to remember, but it's actually really helpful if they give this to you on the exam, and sometimes they do. Sometimes instead of just telling you that the pulse is wiry or the pulse is weak, they'll specify a certain position. So they'll tell you, for example, the right guan position is weak. So if you know the right guan position relates to the spleen stomach, then you know it's like a middle jiao or spleen stomach deficiency of some sort. In other words, it's not heart fire, it's not liver yin deficiency. It's something with the spleen stomach, some kind of deficiency there. If they tell you the left guan position is wiry, then that's probably a good indication that, yeah, it's a liver gallbladder issue. So make sure you know those. Also, there's a handout that I gave you for the Chinese medicine theory section, the one that goes over the 6 channels, all that Shaoyang, Taiyang stuff, and the 4 levels, Wei level, Qi level. There are questions about this mixed in on the case study section too. So that handout is fair game for the Chinese medicine theory as well as this. So there will be questions where those are your answers. Oh, it's Shaoyang disharmony. It's, Yang Ming channel disease. It's Yin, that kind of thing. It's Qi level. So you will get some questions mixed in with the case studies on that. Then I had already mentioned about when it comes to treatment principles, go with the obvious, like moxa for cold conditions and such. One other thing is sometimes when it comes to the point selection, and this actually makes it easier, not harder, because it rules out the the opposite scenario. If you're treating an excess condition and they're asking you about needling techniques, well, for excess conditions, you should sedate or drain those points, those acupuncture points you're using. If it's a deficiency condition like Qi deficiency, you would tonify or supplement those points. And sometimes, when they give you the point combinations, sometimes they will specify, for example, like there might be 2 options that are almost exactly the same, except one option lists spleen 3, UB20, Ren 12, and stomach 36, and it says tonify those points. And then the other option lists those same points and says sedate those points. And I mean, hopefully that's pretty obvious. If you're treating spleen Qi deficiency, you want to tonify. So yeah, just be, hopefully that stuff is pretty much common sense at this point. But again, like I like to go through it because it's just sometimes people in the heat of the moment of an exam panic. So I just kind of like to reinforce, like, yeah, go with what you know to be kind of obvious at this point. And one thing I wanted to mention, this is something that comes up and sometimes throws people off. Make sure you look at all the details they provide you for a particular condition because they often give you clues as to what the pattern is. So, for example, sometimes they might say that somebody complains of fatigue. Now, fatigue can mean a lot of things, right? I mean, you could have a common cold and feel fatigued, but sometimes they'll give you descriptions of like what makes that fatigue worse, what exacerbates that fatigue. And one thing you want to remember is fatigue doesn't always mean deficiency. So, like if they tell you fatigue that's worse with activity, okay, that would more indicate that some kind of deficiency, like chi deficiency or something. If it's worse with activity, better with sleep, then that would more indicate like some kind of deficiency. But sometimes people have fatigue that's actually better with movement, better with exercise. That would typically indicate more of like a chi stagnation pattern. They're better with movement. So don't make sure you don't always see fatigue and just automatically think, oh, they have chi deficiency. There are people like, for example, like you're in class all day. You're sitting down, long classes, 3 hours. You're sitting there, you're looking at a board. It's a lot. It could be tiring. And by the time the end of the day comes, you have a night class, you are fried, you are tired, you feel like you're going to pass out, but you kind of force yourself, I need to go to the gym, I need to go to yoga. And you feel better after that. Moving your body, oh, I feel so much better that I went to yoga. That would indicate like that your fatigue was more about stagnation than it was about deficiency because you were better with moving your body. So always like kind of think about things like that. But keep in mind the Chinese medicine is often very logical with that kind of stuff. Another example of something like that is sometimes people have pain with their menses. Sometimes they'll emphasize in the description, they'll say that the pain was worse leading up to their menses, but then it was better once their menses started. In other words, once they got some bleeding, their pain improved. That would indicate a stagnation pattern. They were better once they got some bleeding, once they got some movement, that actually improved it. Whereas if they were worse after menses, that would more indicate blood deficiency. The idea that losing some blood made it worse, that would more indicate that they have a deficiency issue. Whereas if losing some blood made it better, that would indicate more of a stagnation pattern. So, there's various clues like that that can sometimes come up in the cases that you want to keep in mind. And now, just of course, I just want to clarify like there are many notes that I already gave you that are just repeat notes from your first year comps that include like standout point functions, that include the various categories and reminders of all the different categories. So this list here is not the end all be all, but this is a list of some like really common ones to come up in some of the point combinations for the case studies. So things like if you're clearing heat, the correct answer probably includes some spring points in it. That stream points are used for B syndrome. If you want to strengthen an organ or channel, you might use the source points or the back shoe points. If somebody has pain or acute conditions or blood disorders on yin channels, a chi cleft point might be in the mix of the point correct answer. And then there's like common influential points. So like UB17 is the influential point of blood. So it could be used for a variety of blood patterns. Liver 3 is a major point for moving liver chi. And of course, liver chi stagnation is a very common pattern. Do 9 is a big standout point for jaundice and so on. Like stomach 40 for phlegm. Almost always, if it's a phlegm pattern, stomach 40 is one of the points in the point combination. LI11, major point for clearing heat. So if somebody has high fever or some kind of heat pattern, LI11 is a very common point to be in the correct point combination. So you could see it kind of goes on and on. If they have damp accumulation, spleen 9 is a biggie. There's a few standout combinations that I mentioned. Like they don't even necessarily need to be a combo, but like SI6 and GB27 are pretty major points for benefiting the eyes. So this is just going to remind you some of the really common ones that come up in point combinations that therefore come up in these case studies. So again, don't treat these as the only points to study, but for sure know these because they're very common points in these point combinations. But of course, there's other handouts that I've given you that include, a bunch of other points. All right. So anyway, that should basically cover what you've got to prepare for the comps. And of course, the practical is very, very straightforward. All you have to do is you'll get an appointment time. You have to locate 10 points in 10 minutes. It's the exact same scenario as you already did for first year comps. You just have to do it again, 10 points in 10 minutes with the stickers. And then you have to do clean needle technique, which is just the clean needle technique part. You don't have to do the moxa or the cupping that you had to do on first year. Just the clean needle stuff, the whole wash your hands, set up your clean field, that kind of stuff. So yeah, we have pretty much gone over everything. You should have what you need to be successful. If you're watching this in the next couple of weeks, hopefully you're not waiting till the last minute and you're watching this somewhat soon. The only thing I could say is just don't wait until the last minute. It's a lot of stuff. It's very passable, but it is a lot of stuff to retain if you're waiting until like the week of the test to start studying. So I would just say like little by little, you want to be looking at this stuff. All right. So if anybody's got any questions on anything, feel free to reach out to me. I'm accessible by email and everything. Don't hesitate to reach out. I'm happy to answer any questions. But yeah, if you go through all this stuff, you should be set up for success. All right, everybody. Well, I will wish you the best of luck, wish you good fortune. I'm sure you all do great. Be in touch if you have questions. And any of you New York students, I mean, I should still be reachable by the same email and everything if you ever need to reach out. But in case we're out of contact, I just wish you all the best going forward with this whole transition and everything. I know technically next term we're still one college, but I guess we're not sharing classes anymore. So New York's sort of going off on their own starting next term. So anyway, best of luck on everything and see you around.